very much for that kind introduction. I'm just going to get my slides up here. Oops. Okay, so thanks again. Welcome, everybody. Good evening. It's lovely to be here. I wish it were possible to be in Egypt in person at present. So what I've been asked to do is to give you a little bit of an update on thyroid and pregnancy, sort of beyond what we saw in the 2017 guideline. I have nothing to disclose, and I believe you heard a little bit about this guideline yesterday, but the 2017 guideline was co-chaired by myself and Eric Alexander. And at the rate of thyroid publication in pregnancy currently, I estimate there probably have been about 2,000 publications in this area since we completed our literature review for the guideline. And therefore, there are some places where I think, updating is going to be essential. So what I want to focus on today is not all 2,000 papers. That would be well beyond the scope of this talk, but to focus on some of what I think are the highlights in terms of what's changed recently. So a little bit of new data regarding thyroid function testing in pregnancy, regarding subclinical hypothyroidism in pregnancy. I think one of the areas where there's the most new data is in the realm of thyroid autoimmunity in pregnant women. Couple new studies regarding Graves' disease in pregnancy, and then finally a little bit of new data regarding thyroid function screening. So to start with, this is not new. We know that thyroid function changes over the course of gestation, and that one of the drivers of that change is serum HCG. So when HCG levels are high, they stimulate the thyroidal TSH receptor. So high HCG will drive increases in free T4, which will then feed back at the pituitary and cause concomitant decreases in TSH. So TSH tends to be lower in the first trimester of pregnancy than outside the pregnancy setting. One area of controversy really over the last 15 years or so has been how low is it? What is truly a normal TSH in pregnancy? And one twist on this question that's really new in the last few years is this study looking at the associations between maternal thyroid function and HCG, but stratifying for the first time by antibody status. And it turns out that women who have positive TPO antibodies have sort of a different thyroidal response to HCG than women without. So if you look on, these are data from two different cohorts, which is why the figures are sort of duplicated here. But if you look on the left-hand panels of each of these sections of figures, you see that there is sort of the expected positive association of serum HCG with free T4 and the expected inverse association of HCG with TSH in women who are TPO antibody negative, but that you really lose those associations in women with the TPO antibodies. So they behave a little bit differently in pregnancy, and instead of seeing that decrease in TSH in early pregnancy followed by a slow rise, what we may often see is in fact a slight increase in TSH with pregnancy, which may persist. So I think these new data add strength to prior recommendations about following TSH closely in women who are known to be TPO antibody positive in pregnancy. And also, really importantly, in deriving reference ranges for thyroid function tests in different populations around the world. We said in the guideline that it's really important to define those reference ranges in appropriate populations. So those would be women without known thyroid disease, with optimal iodine intake, which in some parts of the world sort of precludes doing these studies. And importantly, with negative antibody status, and I think that caveat about you need to really define these reference ranges in women without TPO antibodies has become more important. We had recommended that for regions where there are no assay-specific, trimester-specific, sort of optimally derived reference ranges for thyroid function in pregnancy, which is frankly most of the world, including where I practice, that one can instead take the non-pregnancy upper limit of normal and decrease that value by 0.5. So for most assays, that will put the upper limit of normal for TSH in pregnancy somewhere around 4. I think for the most part that ongoing studies that have been published since 2017 have largely strengthened that recommendation, although there's a little bit of variation in different places. And interestingly, the American College of Obstetrics and Gynecology, or ACOG, has its own set of thyroid and pregnancy guidelines, and they have just been revised. They were published in May. And I'm going to reference these a couple of times because the obstetricians sometimes think about these issues a little bit differently from the endocrinologists. But here, with regard to what is a normal TSH, ACOG chose to echo ATA, and in this very recent guideline is suggesting the same thing. Upper limit for TSH probably should be around 4. Now, with regard to subclinical hypothyroidism in pregnancy, another area that has been tremendously controversial, and important to note that as of 2017, when we drafted the last iteration of the guidelines, this was sort of the state of the science with regard to whether or not subclinical hypothyroidism in pregnancy is associated with adverse obstetric consequences. So in 2016, there were 18 cohort studies in the world literature that had looked at this. And based on sort of aggregated data from these cohorts, it looked like women who were subclinically hypothyroid were at increased risk for pregnancy loss, for placental abruption, for having preterm rupture of membranes, and for having children with neonatal death. Note that one of the outcomes that has been looked for in many studies that did not achieve statistical significance in this analysis was preterm delivery. But again, we have a number of cohort studies in the literature since this time. I'm not going to focus on all of them, but I think one that is worth noting is this one. This is a Thyroid in Pregnancy Consortium that has been formed under the leadership of Tim Korovar and Robin Peters, and I should note that I'm one of the many, many authors on these studies. But the first analysis that came out of this consortium is this one, published in JAMA last year. And this combined data from 47,000 pregnant women across 35 different pregnancy cohorts in an individual participant level meta-analysis. So really the best powered analysis we have seen to date in looking at these questions. Here we look specifically at association between maternal thyroid hypofunction and risk for preterm delivery, and found that in fact there did seem to be a significant association in this large data set, that women who are subclinically hypothyroid are at higher risk for preterm delivery. What was a little surprising to me about this analysis is that we also found that maternal hypothyroxinemia, which is this entity we tend to define only in pregnant women where the TSH is normal but free T4 is in the lowest 2.5 percentile. Those women with a low free T4 but normal TSH also seem to be at risk here for having preterm deliveries. And a study that's not a new study, but one that I think helps illustrate why we wrote guidelines the way we wrote guidelines in 2017 is this one. So if you look at this literature, at associations between subclinical hypothyroidism and adverse obstetric outcomes, something that recurs as a theme across different populations seems to be that there's something additive or synergistic about having both an elevated TSH in pregnancy and also having antibody positivity. Usually TPO antibody positivity is what's associated with adverse outcomes. And that's really exemplified by this study from China, in which 3,000 pregnant women in early gestation were stratified here based both on their serum TSH level, but also on the presence or absence of thyroid antibodies. And what you see is that the women with the TSH in the 2.5 to 5 range, the ones that we mostly consider high normal at this point, without antibodies, did not have an increased risk for miscarriage, which was the primary outcome they looked at here. But women who are antibody negative with TSH, it's a little higher. In the 5 to 10 range, you start seeing increased miscarriage risk. As we'll talk about in a few minutes, in women who are antibody positive but really euthyroid, you also see increased risk for miscarriage, but the risk is highest when both of those risk factors are present. So in the women with a TSH in the 2.5 to 5 range and positive antibodies, the odds ratio for miscarriage goes up to about 5, and it doubles to almost 10 when the TSH is frankly elevated in the 5 to 10 range and those antibodies are present. Now, the other important aspect of thinking about whether or not we should be treating women who are mildly hypothyroid relates not to the pregnancy outcomes, but to the child developmental outcomes. And we certainly know from the animal data from the iodine deficiency literature that thyroid hormone is critically important for normal brain development, probably especially in the first trimester of pregnancy. This is an older cohort now looking at IQ in children of mothers with untreated hypothyroidism in pregnancy, and noting that when hypothyroidism is not treated, children on average at the age of 6 here had IQ that was 7 points lower than that of their peers whose mothers had had normal thyroid function during gestation. So maternal TSH in some cohorts seems to predict child IQ, but not across the board. That's not been entirely consistent. What is much more consistent, though, is the association between maternal hypothyroxinemia and poorer child outcomes. And again, a study that I think is particularly important that has come out since the 2017 guideline is this one, which is again a compilation of data from three different European cohorts. Here, looking at associations between verbal and nonverbal IQ in children, sort of measured at different time points in the different studies, between 1.5 and 8 years of age, and maternal T4 levels. In this cohort, maternal TSH did not predict IQ, but the maternal free T4 did. And you can see in the left upper panel that having higher free T4 in a pregnant woman predicts higher verbal IQ. That's a linear relationship. But that the relationship between maternal free T4 and child nonverbal IQ is not linear. It seems to be U-shaped, such that women with both low and high free T4 levels seem to be at risk for having children with lower nonverbal IQ. And that, I think, has implications as we think about risk for overtreating pregnant women with thyroid hormone. Now, we think there are adverse associations between subclinical hypothyroidism, hypothyroxinemia, and these child developmental outcomes and pregnancy outcomes. So then the key question is, well, if we treat pregnant women with levothyroxine for these conditions, can we actually make things better? And here there are a limited number of trials, a couple things that are new since the guideline. This is one of those trials that's new since the guideline. This is from Iran, from Faridun Azizi's group. They took women who were TPO antibody negative with a TSH between 2.5 and 10 in the first trimester of pregnancy and randomized them to low-dose levothyroxine versus no treatment, and followed to look at preterm delivery as the outcome. And what they saw in the study was there was no difference between the treated group and the untreated group with respect to the preterm deliveries, but in sensitivity analyses, when they restricted the women to those who had a truly abnormal TSH at baseline, the TSH above 4, there was perhaps a benefit in that group, although of course the study was really not powered to look at that subgroup. There are 2 trials in the literature that relate to whether treating hypothyroxinemia and subclinical hypothyroidism in pregnancy improves child cognitive outcomes. This is not a new trial. This was present before the 2017 guideline, but I'm going to show you they've got a couple updates to their data. So this is really a landmark trial led by John Lazarus, published in the New England Journal back in 2012, in which they screened 22,000 pregnant women in Europe in order to randomize to one of 2 strategies. So women either were randomized to the screening group, in which they were treated with high-dose levothyroxine, 150 micrograms a day, if they had a serum TSH in the upper 2.5 percentile or free T4 in the lowest 2.5 percentile. The controls were women who had blood drawn in pregnancy but not measured for thyroid function until after babies were delivered, so there'd be no ethical problem with failure to treat. They wound up with about 400 women in each group. They followed their children till the age of 3, measured IQ as the primary outcome, and saw no difference. So a negative trial with 3 important caveats. One is that treatment was initiated at a mean of 13 weeks gestation. So if the first trimester truly is the most important window for this effect of thyroid hormone on brain development, they may have missed that window. The second is that the levothyroxine dose was high, and there's a concern that perhaps in this trial, before knowing that U-shaped relationship I just showed you between maternal free T4 and child nonverbal IQ, they may have overtreated, and they may have taken women from having free T4 that was too low and made them have free T4 that was too high, and therefore missed an IQ benefit. And the third issue is that they assessed child IQ at the age of 3, whereas most experts think it's not really a very reliable predictor of long-term developmental outcomes if it's measured below the age of 5. So in response to that third caveat, the CATS study group has in the last couple of years published a couple of additional papers following up those of the children they still have access to at the age of 9.5 years. So in 2018, they published a follow-up looking at IQ at that age 9 group in these children of the treated and untreated mothers in the study, and again found no difference, suggesting there's probably sort of confirming or adding some confirmatory evidence to that initial negative finding. I think maybe more interestingly, very recently, they've published another follow-up here looking not at child IQ, but looking at neurobehavioral outcomes. And so they looked at symptoms of attention deficit hyperactivity disorder, autism spectrum disorder, just abnormal behavior questionnaire scores, again, in the children of mothers who were and were not treated with levothyroxine in this initial trial, and found interestingly that the mothers who'd had the highest free T4 in that top 2.5 percentile had children who seemed to have more neurobehavioral deficits, so higher risk of attention deficit hyperactivity. And this does, again, suggest perhaps that we need to be cautious about over-treating if we're treating women with mild thyroid failure in pregnancy. Oops, sorry, I just went backwards instead of forward. Here we go. So the second trial, and this is cheating a little bit. So the second big trial in this area was done in the US. This was sort of partially known to us at the time we drafted the 2017 guideline because we'd seen the abstract data, but not the final paper. And here, this is sort of similar to the CATS study I just showed you, even bigger. So this is a multi-center US trial in which they screened 100,000 potential participants in order to place women into one of 2 parallel randomized clinical trials. One in which women with hypothyroxinemia were given levothyroxine versus placebo. And the levothyroxine in these trials was dosed at a more rational lower level. And the other parallel trial here is women with subclinical hypothyroidism, defined as a TSH greater than 4 with normal free T4, again randomized to levothyroxine versus placebo. Children were followed till the age of 5, so they were tested for cognitive outcomes at sort of a more robust age. There was almost no loss to follow-up. This was beautifully done. And what they found, again, was a negative study. So no difference in child IQ at the age of 5 between women of the treated and untreated mothers in either of these studies. Again, I think a couple of important caveats here. One is that the mean was 17 weeks gestational age at randomization. So if that first trimester is important, they really missed it here. And the second is that you note that the IQ in the children of the treated mothers was 3 points higher than the IQ of the children in the untreated mothers in both of these trials here. The study was powered to see a 5-point difference, so this is not a statistically significant result, but a suggestion perhaps of a trend. And if you look at a lot of the observational literature, often the 3-point IQ difference is about what you expect to see. So nobody is going to fund the trial that's going to look at the 3-point IQ difference. I'm not sure that's a feasible trial to do, but I think we're left with some questions. It is important to note that in this NIH multi-center trial, in addition to looking at child IQ as a primary outcome, they looked at every possible obstetric outcome I think they could have and saw no difference with treatment. So reasonable to say that initiating levothyroxine therapy for mild hypothyroidism at week 17 is not helpful. And what we don't really know is whether initiating therapy earlier is of benefit or not. So in our guideline in 2017, we recommended a stepwise approach where if the TSH is elevated, consider checking a TPO antibody because that may help you make some treatment decisions. Women with a TSH greater than 10, we said just treat with levothyroxine. We treat those women outside the pregnancy setting for the most part. Women who are TPO antibody positive and have an elevated TSH in the 4 to 10 range, again, we said treat those women. There's more evidence of adverse obstetric complications in that group if you don't treat. For women who are normal, where the TSH is less than 4 and the TPO antibody is negative, do not treat. There's nothing to treat there. And for the in-between groups, where the TSH is high normal, 2.5 to 4, but there are antibodies present, or where the TSH is elevated, 4 to 10, without antibodies, we're really not sure. There's no good trial evidence of benefit here. But low-dose levothyroxine, probably a pretty benign intervention, and I think many of us in endocrine do wind up treating these women I think we're going to need future trials to know for sure whether it helps. Finally, we recommended against treatment of maternal hypothyroxinemia because there are precisely 0 trials in the literature right now showing a benefit there. Now, interestingly, again, ACOG, our obstetric colleagues, have just updated their guideline, and they looked at the same evidence, which is clearly imperfect evidence, and came to different conclusions. So ACOG recommends treating overt hypothyroidism, which everybody agrees on, but they don't treat any women with subclinical hypothyroidism, regardless of TSH level of elevation, regardless of antibody status, and ACOG really did not comment one way or the other on maternal hypothyroxinemia. As a reminder, we recommended that if you're going to treat a woman with levothyroxine, the target of treatment should be a TSH less than 2.5. I don't think there have been new studies since the guideline was published that really make me think we need to change that recommendation. And ACOG in their guideline made the same recommendation as well. So I think everybody largely at the moment is in agreement that if there's going to be treatment, this is the treatment target. Now, thyroid autoimmunity in pregnancy has gotten more interesting in the last couple of years. So we've known for a couple of decades now that having TPO antibodies, even in euthyroid women, is associated with a higher risk of miscarriage. And we have known for some time also that there's a higher risk of preterm delivery. Again, this is that same consortium study I showed you earlier that in addition to looking at the association of preterm delivery with subclinical hypothyroidism, we also looked at TPO antibody status and confirmed that TPO antibodies, but here not thyroglobulin antibodies, do seem to be associated with higher preterm delivery risk even when thyroid function is normal. So what we don't really understand about all these cohorts is why. It's not clear why having positive antibodies causes higher risk of pregnancy loss. It's possible that it's mediated by thyroid function that starts out normal in pregnancy but then becomes low in the women who have the thyroid autoimmunity. It's also possible that the thyroid autoimmunity has nothing to do, or that the pregnancy loss has nothing to do with thyroid status, and that the thyroid autoimmunity simply is a marker for other forms of non-thyroid specific autoimmunity that maybe are really the culprit. And when we don't understand mechanism, it's really kind of hard to figure out what the appropriate therapy should look like. There was one older trial in the literature from 2006 that suggested that levothyroxine therapy for euthyroid pregnant women might decrease risk for preterm delivery and for miscarriage. We've been waiting for years to see if that could be replicated, and bottom line, as I'm about to show you, is it looks like it can't. So this is a trial that was published in 2017, again from Faridun Azizi's group, so the companion to a trial I showed you earlier. Here they randomized women in early gestation who were TPO antibody positive and had a TPO up to, had a TSH up to 10. So a mix of subclinical hypothyroidism and euthyroidism in this population. Randomized to low-dose levothyroxine starting at week 11. Primary outcome here was preterm delivery. And they did see a significant reduction in the preterm deliveries in the treated compared to the untreated women. Again, with an important caveat that in the sensitivity analyses, this benefit really only seemed to accrue to the women who actually had subclinical hypothyroidism, where the TSH was greater than 4 at baseline, and they didn't see a benefit in sensitivity analyses to the women who were truly euthyroid. 2 much larger trials have subsequently been published. This one comes from China. This is Postal, published in JAMA. In this trial, women were screened pre-conception, and if they were euthyroid and had TPO antibodies that were positive, and they were going to undergo IVF, they could be randomized to low-dose levothyroxine versus no therapy. That was started pre-conception, continued through delivery. Primary outcomes they looked at here, miscarriage rate, clinical pregnancy rate, live birth rate, did not differ with the therapy. So no benefit from levothyroxine in this trial. And this very similar trial came out of the UK, published last year in the New England Journal. So this is the tablet trial, similarly looking at women pre-conception. So here, women with a history of recurrent miscarriage or a history of infertility were screened pre-conception. Some of these women underwent IVF, not all of them did. They were eligible for inclusion if they were euthyroid, TPO antibody positive, randomized to low-dose levothyroxine until delivery versus placebo. And here, the primary outcome was live birth at least 34 weeks gestation, and again, no difference. So now we have 3 essentially negative trials. What we had said in the guideline, note it's a weak recommendation based on low quality evidence. We'd suggested consideration of treatment of these euthyroid TPO positive women with low dose levothyroxine, but I think these new trials really call that advice into question, and I am no longer doing this in my own practice. I think unless we get additional evidence, this is probably not worth pursuing. Now, with regard to Graves' disease management in pregnancy, a lot of the changes to recommendations in the 2017 trial were really based on this particular study. So this is a Danish registry study published by Peter Lauerberg's group in 2013. And what we had known for decades was that methimazole is teratogenic. But what this trial taught us, or sorry, this registry study, it's not a trial, taught us for the first time was that PTU also seems to be associated with birth defects. They're associated with defects in different organ systems from methimazole. They're probably not as severe or as life-threatening. But all of a sudden, after this study was published, we sort of realized that there isn't necessarily a safe anti-thyroid drug in the first trimester of pregnancy. And we certainly know from the literature that uncontrolled overt hyperthyroidism is also not safe in pregnancy. And that has led to some challenges in therapy. What is new since the guideline was published is 3 more registry studies looking at very large groups of mother-child pairs, looking again at this question of what is a teratogenicity of both PTU and methimazole. And I think results are actually getting a little bit less clear, maybe rather than more clear, based on the new evidence. So a very large Korean study with almost 3 million participants looked at that risk of birth defects with PTU and methimazole use and found that both were associated with birth defects, again, with different organ systems, sort of replicated the 2013 Danish study, except that the absolute risk of the birth defects with PTU was lower than had been reported. The Danish group then published a larger series over sort of a longer time period, so it included a larger number of mother-child pairs, and were able to replicate their earlier results that they saw an association of methimazole with birth defects, and there was an insignificantly increased risk of birth defects with PTU, but it didn't really achieve statistical significance. And then a smaller registry trial in Sweden in 2017, here an N of only 600,000, so maybe not big enough to see effects, but they didn't actually see birth defects associated with either PTU or with methimazole. So I think we're in a situation where it's a little bit questionable whether there are truly birth defects associated with PTU, but I think to be on the safe side and to be conservative right now as clinicians, we should assume that there are, although PTU is probably safer than methimazole in pregnancy during organogenesis if you have to pick one of them. So the concern about birth defects and PTU led to recommendations in the guideline that really emphasized preconception counseling when women are known to have Graves' disease before pregnancy, consideration of definitive therapy with radioactive iodine or thyroidectomy, so there's no need for anti-thyroid drug in early pregnancy. And certainly any pregnant woman who's treated with anti-thyroid drug, probably better to treat with PTU than methimazole. Whether or not to switch back to methimazole at the end of that first trimester, nobody really knows right now, and we didn't provide guidance either way. And finally, my last minute or so, want to talk about whether or not we should be screening every pregnant woman for thyroid dysfunction. If we do that, mostly we're going to find a lot of subclinical hypothyroidism, and we're not quite sure, as I think I've shared with you, we're not sure if we can treat that and make a difference. And probably for that reason, guidelines from around the globe are all over the place. I always say, whatever you're doing in your own practice, you're in line with somebody's guideline because, you know, it's all here. ACOG, again, the American Gynecologists and Obstetricians really are kind of anti-testing in general, recommend testing only for known thyroid disease or clear symptoms, whereas in some countries there are recommendations for screening everybody. The ATA kind of came down in the middle, so I couldn't really recommend for or against universal screening. But because we don't want to miss overt hypothyroidism, recommended a very broad group of risk factors in order to consider sort of case finding of high-risk women. And this has now been tested. So the last study I want to share with you is this one. that this looked at a strategy of universal screening versus the ATA's case finding recommendations retrospectively in a single center, and found that using the ATA definitions, about 2/3 of women would be defined in this high-risk group who should have TSHs checked, that universal screening and case finding were roughly comparable in terms of finding the overt hypothyroidism, which I think is what we care about most, although universal screening will certainly capture more women with subclinical hypothyroidism. So with that, I would like to thank you very much for your attention and look forward to an opportunity for questions and answers later in today's session. Thank you.